know us. We are a digital healthcare company driven by a mission to create technology that changes what's possible for clinicians and patients. This is number 6 in our series of learning and sharing virtual events for MHSTs and others supporting mental health in schools and colleges. The webinar is designed for those supporting mental health in schools, providing early interventions and in educational settings, but all healthcare professionals are very welcome, and we hope you find it useful. I'm very pleased to be able to welcome Dr. Rachel Stirland today. Rachel is a clinical psychologist based at Seraph Psychology and has a wealth of experience working with both young people and adults. During her clinical training, she specialised in cognitive analytic therapy and compassion-focused therapy as her favoured therapeutic approaches. If you do have any questions for Rachel during or after the talk, please feel free to post them in the chat channel. We have a team here behind the scenes who will collate them, and we'll get through as many as we can immediately afterwards. And just before I hand over to Rachel, we are recording this session, so if you prefer not to be seen, please keep your camera off. Okay, Rachel, over to you.
Lovely, thank you, Jen. So yeah, lovely to see so many of you here today. Self-harm is a topic that I enjoy talking about. I have a big interest in. You know, as Jen mentioned, I kind of work across a variety of age groups, and I kind of see self-harm, complex mental health as my specialist area. So not only do I work in Seraph half the week in a private practice, but I also work at Bristol University and run or co-run a specialist pathway called Sherpa, which works with university students who have complex mental health difficulties, including self-harm. So I'm really excited to talk to you all today about this. I'm just going to share my slides. So hopefully you can all see that okay. So yeah, today I'm going to be talking about self-harm in children and young people specifically, although I would say that a lot of the stuff we're going to cover today is going to kind of fit with an adult population as well. So in terms of what we're going to be covering today, the first bit is just really kind of setting the scene, getting people thinking about kind of self-harm and what we mean by this and what the current context looks like for children and young people. We're then going to be moving on to think about, you know, why people self-harm, why young people and children self-harm, some of the kind of functions that it can serve for people, and also kind of think about what you might look out for if you're either kind of working with a young person or perhaps are a parent or involved with young people in some other way. We're going to be thinking about young people's views in terms of how professionals respond to them around self-harm, and hopefully dispel some of the myths as well that are around kind of talking about self-harm. Then we're going to move on to think about what can help, and it is going to be very much a whistle-stop tour of this. There's so much we could cover, and I'm aware we're kind of short on time today, but I'll try and give you kind of a general overview of what can be useful, and then we'll think about some kind of alternative methods that we can introduce as well. And then we're going to finish off with an acronym called PAUSE, which is a way to kind of hopefully remember some of the key points from today, and then look at some kind of further resources that you can use. And then we'll have our Q&A section at the end, and I'm going to try and stick to time so that we can have a good chunk of time at the end today to kind of field your questions that come in. So to start off with, I just wanted to kind of define what self-harm is really and what we mean by this. So in a general sense, when we're talking about self-harm, we're thinking about the idea of causing harm to ourselves. Now, this can be intentional, so it might be that we deliberately hurt ourselves in some way, perhaps through cutting ourselves with something sharp, or perhaps through taking an overdose, but it can also be accidental. So sometimes people will engage in quite reckless behaviour, for example, that causes them harm to themselves accidentally, so that's not kind of their original intention. It can take many, many different forms in young people. So as I mentioned already, it could be cutting, it could be overdosing, burning is a very common one. It can also be use of drugs and alcohol in a problematic way. It can be forms of eating, so it could be restrictive eating, it could be binging as a form of self-harm, it could be purging as well. And also kind of some sexual behaviour can be classed as self-harm. So if people, again, are engaging in that kind of risky or self-destructive behaviour, we might class this as self-harm too. And it's really important to recognise that there can be many, many reasons for a young person or a child self-harming. It can have lots and lots of different functions for them, which I will come back to on the next slide. So in terms of kind of the context we find ourselves in at the moment, I just wanted to sort of share some statistics. I'm aware some of these are a little bit out of date, but in terms of kind of what we see in terms of the rates, in 2021, it was estimated that 1 in 6 young people had a probable mental health problem. And a couple of years before that, 24% of 17-year-olds will be found to kind of have self-harmed at some point in the last year. So what we're talking about here isn't kind of an unusual thing in terms of our children and our young people. Sadly, it is quite a common occurrence. And of course, it's important to note that whilst for some young people who are self-harming, they might have a diagnosed or a diagnosable mental health problem. That's not always the case. So whilst it's more common when people have mental health difficulties, self-harm can kind of exist on its own as a behavioural response to other stuff. What we know is that over the years, particularly over the last few years, the rates have been increasing quite significantly in terms of how many young people are self-harming. Now, the difficulty is working out why. It's quite complex. There are theories around, what might be causing this. I think some of it is partly due to just awareness and people talking about it more openly, or kind of discussing mental health generally more openly. So that's going to increase the rates. But I think there has also been a genuine increase in terms of using this as a way to cope with distress. One of the things that's often talked about a lot in relation to this is perfectionism. And actually what we see in a lot of young people today is a really high level of perfectionism. And this is very closely associated with self-harm rates, and actually more so than kind of other things you might assume, like social media, for example. So it's really important to kind of be mindful of these other elements that might be having an impact on someone's likelihood of self-harming. And as I said previously, kind of the mental health difficulties generally can be a factor too. I think it's also worth mentioning the effect of the pandemic. Again, anecdotally, we've seen an increase. I don't know if the figures necessarily support that. And interestingly, we've actually seen an increase coming out of the lockdowns rather than kind of during, which you would perhaps anticipate in terms of kind of often when people are in a very stressful, unsafe situation, that's not when they respond in a traumatic way like self-harming to it. It tends to be afterwards. It's kind of the aftermath of the event where distress gets much, much higher. So again, that's worth kind of thinking about for our young people. So coming back to this idea of function of self-harm. So sometimes you'll hear professionals refer to this as a function. Essentially, that's a fancy word for the reason for self-harming. So, why do children self-harm? Well, as I mentioned earlier, there are lots and lots of different reasons for this. So for some young people, it might be as a way to get rid of emotional distress. So they might do it to kind of release the emotional tension or the emotional distress they're feeling in their body. It might be to block or avoid emotions completely. Some actually use it as a way to dissociate, so to completely detach from reality or from their kind of experiences that they're having because they're just so overwhelmed by them. But the opposite can also be true. So you may see some young people who are self-harming as a way to ground themselves, that actually are not feeling anything. I feel numb, I feel empty. And so actually self-harm can be a way of feeling something, and that can be preferable for them than not feeling anything at all. It can also be a way to exert control. So if the young person feels particularly out of control of other aspects of their lives, it's something they have control of, it's within their kind of, their control sphere. So that's a really common reason too as well. For others, it can be a form of self-punishment. So you might work with some young people who say, you know, I just really hate myself, or, you know, when I feel like I've done something wrong, I have to find a way to punish myself, and self-harm might be the way to do that. It can also be a way to express distress to others. So, you know, I will quite often work with young people who say, I don't know how to find the words to describe how I'm feeling. I don't know how to express it in any other way. So for them, self-harm can be a way to kind of show others how they're feeling. And alongside that, it can also be a way to elicit care. So some young people may have learned that actually the only way I get taken seriously, or I get listened to, or I get care and attention from others is from harming myself. And of course, this becomes reinforced over time, because usually people do respond when a young person self-harms. So they kind of learn that that's the way to get that need met. And a kind of final point to make around this is that there can be kind of reasons for self-harming that are around actual safety. So you may work with some young people or speak to some young people who say, actually, I do it so that I don't do anything more risky. So quite a few of the students I work with, for example, will cut themselves because actually that's safer than overdosing. And they say, if I don't cut myself, I'm more likely to get the urge to take an overdose. And I know that that's riskier for me. So while seeing someone self-harming can be very distressing and very difficult for us as a parent or a carer or a professional, actually sometimes it's the safer option for them, and it's the better thing for them to be doing, rather than something that's going to cause them more pain, more distress, potentially being kind of life-threatening for them. Now, this list isn't exhaustive, and there are probably many reasons I've missed off here, but these are kind of some of the common ones that you'll see come up. And as we'll talk about later, one of the important things I think with self-harm is exploring this, is trying to unpick what the reasons are, because the way that you then deal with the self-harm is going to be quite different depending on what the function of it is or what the reasons are. So if we think about kind of what we might see in terms of self-harm, there are lots of different signs that you may pick up on. Now, again, this list isn't exhaustive, and it's also important to say that some of these signs might not be indicating self-harm. It may be that there are other reasons for these things. But I think particularly if you're kind of noticing a few of these around, you know, it might be worth kind of gently exploring with the young person, or at least kind of just having it in the back of your mind as a possibility. So one of the common signs that we see is unexplained injuries. So you may notice the person perhaps has cuts or sort of scars along their arm. You might notice bruising in particular places. And I think particularly if it's areas that you wouldn't necessarily get accidental bruising from. So fists can be quite a common one if people have been punching walls, or head as well, if they've been kind of headbutting something. And these are areas that you wouldn't necessarily see bruising kind of from maybe falling over. You may come across tissues with blood on them, which would indicate that the person may have cut themselves. You might spot empty pill packets that don't necessarily fit with maybe how long the person has had the pills. So if, I don't know, someone had a full pack of paracetamol yesterday and today they're empty, you would be potentially concerned about that. Young people wearing long sleeves when the weather is warm. Obviously, I appreciate most of the year long sleeves is quite normal in this country, but you know, if it's a really hot sunny day and you know they're kind of wearing long sleeves or long trousers, for example, that may be an indication that they're trying to hide something or cover something up. And then it's worth kind of just thinking about the emotional side of things in terms of signs. So you may well see young people starting to become more withdrawn, isolating themselves more. You might notice kind of, or they might describe being quite low in mood. There might also be angry outbursts. You know, again, these responses aren't necessarily definite signs of self-harm, but they're things that we do commonly see when young people and children are sort of engaging in this behaviour. They'll have these other elements going on as well. So it's worth paying attention to and keeping an eye out for. So in terms of kind of how young people feel about professionals' responses to self-harm, I thought it would be useful to share some of these quotes with you. Now, these are from students, so kind of 18, 19-year-olds, and they're kind of speaking specifically about the GP practice and kind of the mental health support they get at university as well. But I think it's worth sharing because actually some of these ideas do apply generally to young people's experiences. So they are concerned that their physical symptoms won't be treated as seriously because of their mental health and self-harm. So there can often be this sense that actually this is all I'll be seen as. I'll be seen as a mental health problem, I'll be seen as my self-harm behaviour, and kind of other concerns I have won't be listened to or taken seriously. So that's one concern that people have. Another is that it's important to have someone they trust and someone that they can kind of regularly have that contact with and that consistency with. Now, one of the things we know is difficult in GP practices at the moment is having a consistent GP. So that's kind of been flagged as an issue for young people. But I guess kind of thinking around, you know, what happens within schools, what happens in other areas that children and young people are accessing. Again, being mindful of that idea of consistency, of developing a relationship that can kind of end up in trust with that young person is really, really important and something worth considering. Another young person had talked about this idea of being able to administer basic first aid themselves. This is probably less relevant for the younger children, but might be more relevant for teenagers in terms of kind of thinking about, you know, do they know how to, you know, clean a wound or, you know, or respond to a burn if they've hurt themselves in that way? You know, do they know how to kind of make sure that it doesn't get infected, that kind of thing. So that can be really useful to empower young people to be able to do this for themselves. And I think the thing I probably hear most commonly from young people is this issue around being told it's not that bad. So this real sense of feeling that their distress has been dismissed, that actually it's not that important, that, oh, it could be worse. Oh, actually the cuts are really, really shallow, it's fine. Whilst it can be coming from a very kind of caring and well-meaning place, often that's experienced as very invalidating and can actually escalate someone's distress rather than reduce it. So again, this is just something to be aware of in terms of the language we're using, the way that we're responding when young people perhaps present with these difficulties. I also wanted to share with you some common myths that come up, I suppose generally when people are thinking about self-harm, but also when I've delivered training on this over the years. These are often things that people worry about. So the first myth is that talking about self-harm increases it. I think this is particularly the case when we're dealing with young people, with children. Often adults worry that if I raise this with this young person, it's going to make it worse. There is absolutely no evidence that that is the case. If anything, there is some kind of tentative research that suggests that the opposite is true. So if you talk about self-harm with the young person, if you kind of are open and sort of empathic around it, then it can actually de-escalate distress and kind of reduce the likelihood that the person needs to resort to self-harm as a way to manage their distress. So, you know, please don't worry about kind of raising this as a topic with people, or, you know, if they bring it to you, don't worry about kind of delving into it, because, you know, you're not going to make it any worse. You're not going to increase it. And the same is also true for suicidal kind of thoughts as well. I just want to highlight that. Second myth is that you're responsible for someone's decision to hurt themselves. So sometimes what can happen is we may have had a conversation with a young person, or I don't know, or had some kind of interaction with them at some point, and then we find out later on that they've gone and harmed themselves. And that can leave us feeling really guilty, anxious, maybe worrying that we said something or did something that caused it. So I think this is a really, really important myth to dispel as well, that actually, we aren't responsible for someone's decision to go and harm themselves, even when they're young. And, they largely have that kind of ability to control, and not control, but kind of, I guess, take responsibility for their actions in that sense. And we can't really kind of prevent them or stop them from doing that. If someone wants to engage in that behavior as a way to manage their distress, then they're going to kind of do that. So again, just being mindful of that tendency to take on all the responsibility and try and fix it, when actually that's not yours to take. Another myth that commonly come across is this idea that the degree of self-harm is directly related to the level of distress the person is experiencing. This may be true in some cases, but largely in my experience, the two don't really correlate that well. So, I have worked with young people who are incredibly distressed, but actually are sort of self-harming, perhaps not very frequently, or they may be doing it kind of that lower end of the severity end of the spectrum. But that doesn't mean that they're not very, very distressed. Equally, the opposite can be true. So there can be some people who you might come across who actually their self-harm does seem quite severe, but generally speaking, they're not that distressed. I mean, of course, there's going to be an element of distress, or they probably wouldn't be self-harming, but compared to some others, they might not be as distressed. So again, just making sure you're not kind of prejudging that when someone comes to you is really important. And then the final myth that I want to dispel is this idea that success is stopping the person from self-harming. Again, I think there's a real kind of pull, a real emotional pull to want to make it better for the young person or the child. And from our perspective, stopping them self-harming would be a great outcome potentially. But actually for the young person or the child, that might not be how they feel about it. As we talked about earlier, it could be that doing that self-harm is stopping them doing something worse. And so actually for them, it's really important to keep it as it is. For others, it might be, actually, I'd like to gradually reduce this over time, but I'm not sure I can fully give it up yet, or I'm not sure I can stop. And that's okay too. So it's really important that we don't kind of see this as, oh, if I don't get the person to stop self-harming, I failed, or they failed. And because often that's not what it's about. It can be a lot more complex than that when we break it down. So if we think about what can be helpful in terms of supporting young people, supporting children if they are self-harming, there are a few kind of key points I wanted to just make you aware of here. So the first thing is around managing our own distress. Now, I know that this is easier said than done, particularly if we have a strong attachment to the child or the young person, we really care about them, we want to support and help them. It can be very, very distressing to see them distressed or to see them harming themselves in some way. It's really important though that we do try and kind of manage that in ourselves. What we don't want to do is escalate their distress by responding back in a panicky way or in a distressed way ourselves. So finding ways to kind of learn how to regulate that for ourselves is really, really important. If the child wants to talk about it, then kind of encouraging that talking, being open, being curious is really, really helpful. But it is really important that we don't force this. So I'm sure you'll all have worked with or come across young people who are, quite closed off, don't want to talk to you, don't want to, explore this stuff. That is okay. They're within their rights to do that. And actually, if you try and force the conversation, or you try and force the topic, often that can lead to them closing down more. And so there's something about kind of encouraging a safe space to talk, but not kind of pushing it if the person doesn't want to. In terms of how we then respond when the person's talking, validation, really, really important. So what we mean by validation is this idea of kind of acknowledging how they're feeling. So not saying, oh, that doesn't sound that bad, but saying, actually, this sounds really tough for you right now. I can really see how distressed you are. I can really see that you're trying to find a different way to manage this, or, you know, whatever it might be. And within that, kind of empathizing with their situation, empathizing with perhaps the emotion they've described, or empathizing with how they're trying their best to kind of manage a difficult situation. And then thinking about praise. Now, again, it's sort of how appropriate you feel this might be with a young person. But, you know, if someone's come to you and spoken about this stuff, and you can see, or you know from your previous experience with them, that it's really hard for them to talk, you can praise them for, you know, for saying that. So, you know, well done for coming and sharing this with me. I can see how hard that was, for example. And, you know, again, a bit of praise can go a long way in terms of reinforcing that that behaviour, and kind of encouraging them to talk more again with you in the future. Avoiding judgment, really, really important. Again, I think it's really easy to slip into this, because self-harm isn't pleasant to see or to hear about, particularly in young people. So, you know, being mindful of our own judgments, our own views, our own beliefs. Again, if we're a very strong believer that no one should ever self-harm, then, you know, being aware that you're going to be coming into that conversation holding that view, and trying not to kind of impose that on the child is really important. As I mentioned earlier, not telling them to stop or reduce. It's more about exploring with them what they want to do. Telling them to stop can alienate them, and it might stop them coming to speak to you again in the future. So really, kind of what you're wanting to do is explore how they feel about it. You know, how do you feel about your self-harm? Do you know why you're self-harming? Do you know what it does for you? Does it have a purpose for you? Does it have some advantages for you? You know, how does that work? So really kind of being curious about that with the person, if they're wanting to talk about it. And then from there, you can help them problem solve and plan. So actually, if the person's saying, you know, I really, really hate self-harming and I want to stop it, then of course it's entirely appropriate to look at ways that you might support them to do that. If on the other hand, they're saying, actually, my self-harm isn't the problem, I'm more concerned about my anxiety, for example, then you might look with them at kind of ways to manage the anxiety, or kind of signpost them appropriately to support for that. But coming up with kind of a plan, even if that's just let's meet again next week and talk about this some more, can be a really useful way to kind of end the conversation. And the final bit just to consider really is around when to signpost for further support. Now, I'm aware that CAMHS at the moment, I don't know how it is everywhere in the country, I suspect it's similar across the board. CAMHS is really, really challenging to get into. I'm sure those of you who are working professionally will already be aware of this. Part of this is that they do have quite strict kind of criteria that has to be met for young people to be referred in. So I think they generally say that the mental health difficulty has to be quite complex and severe, and it has to be enduring. So I think they define enduring as kind of 3+ months. So with this in mind, if this is the first time the person has self-harmed, or the first time they're kind of brought it to you and it's quite a new thing, it's unlikely that you're going to be able to get them that support through CAMHS. It may be that the first step is going to the GP and actually kind of seeing what the GP thinks in terms of available support, or working alongside them if that's within your remit, or considering signposting to other services and other resources, which we'll kind of come back to at the end of the session today. So yeah, I think if in doubt, it's always worth signposting. It's always worth kind of sending you know, to the GP if you're really not sure about that level of risk and complexity, because, you know, it's their job to kind of assess that to some extent. Okay, so thinking about what we can do to support the young person. So if they're saying, look, I really do want to stop my self-harm, or I want to reduce it, or I want to learn coping strategies for my distress so I don't end up self-harming, then these are some alternative methods that can be really useful. Now, I think it's really important to say that a lot of the time these can get a bit of a bad reputation. I think there are a couple of reasons for that. I think firstly, sometimes young people can feel fobbed off if you give them a list of these methods. So what I would say is that if you're going to recommend any of these, talking it through with them kind of fully and sort of trying to adapt it or make it individual for them is really, really important. The other point is ideally trying to match it to some extent to kind of what else is going on for that young person. So, you know, if they've said to you, I feel really overwhelmed by anxiety, and to get rid of my anxiety, I self-harm. So you'd be thinking, okay, well, I want to try and find a method, alternative methods that's going to address the anxiety and is going to be a way to bring that anxiety down. Whereas if they're saying to you, actually, I don't feel anything, so I'm using it to ground myself, or I'm using it to feel something, again, you're going to be wanting to pick an alternative method that's going to fit with that presentation. So those two things could look quite different. So those are just some kind of flags to be aware of when you're thinking about this. In terms of these methods, again, this isn't an exhaustive list. There are loads and loads out there, and if you Google it, there's so much great stuff that you can do with young people around this. The elastic band method is one of the most common ones that's talked about. Again, it needs to be done on the site of the harm, though. I don't know how many times I've heard people say, yeah, I was told to ping an elastic band against my wrist, when actually they've been cutting their legs. So that's not going to do anything. So making sure it's kind of where it needs to be, and also thinking about that function. So if the person's saying, the reason I cut myself is because the pain feels good, then an elastic band makes sense. But actually, if what they're saying is, I like the feeling of something being released, an elastic band probably isn't going to be very effective, because it's not going to serve that same function. Similar with kind of things like ice cubes. Again, what you're wanting to do is place that ice cube on the site of the harm, or you can use ice cubes or cold water, which I'll explain in terms of tip in a second, to kind of manage the emotional heat and bring the distress down. So they talk about kind of having it in your hands or having it on your face. The ideal actually is to get an ice pack and put it over the eyes. Again, I'm aware this might not be possible in school, but if the child's at home, they might be able to do this. TIP is something that's taken from DBT. So it stands for temperature, intense exercise, paced breathing, and progressive muscle relaxation. And essentially what you do is you'd work through all four of these. It's a really, really effective way to bring down very high levels of emotional distress, which is generally speaking when people are more likely to self-harm. So temperature is bringing down your temperature very quickly. So something called ice diving is often recommended, where people dunk their heads into very, very cold water, hold the breath for 30 seconds, and then come back out. You do need to be careful with this if someone has a heart condition, but otherwise it's safe. Or you can use ice and ice packs. Intense exercise would be doing something very intense, high intensity exercise for usually a few minutes. That could be jumping jacks, running up and down stairs, doing some weights, whatever that might be. Paced breathing is any form of kind of breathing exercise that works for the person to help them feel calmer. And progressive muscle relaxation is a form of bodily relaxation. Again, if you Google it, you'll see lots of examples of that. So this can be really, really effective. And again, if you're able to, working through this with someone, doing the different steps alongside them can be a really useful way to see if this is going to work for them or not. Grounding is a massive topic. Not going to go into too much detail of this, but just to say, to help a young person ground themselves, it's basically anything that kind of helps them feel present and kind of connected to their environment, or to sort of the ground, the world around them. So this can be kind of physically grounding, like pressing feet really hard into the ground, or sort of pressing hands onto a chair if they're sitting down, feeling how their back and their legs are supported against the chair. You might get them to use other sensory things to ground. So certain smells or certain sights or certain sounds can be very kind of effective as grounding. And again, if you look that up, you'll find lots and lots of examples. Soothing activities are slightly different. from grounding. So again, these can use different senses, but essentially it's any activity that's kind of calming things down. So grounding's a bit more punchy often, soothing is kind of more calming, more relaxing. So again, using smells, using touch, using things that can kind of really help the person to feel soothed and safe. Connecting with others is a really, really common one that particularly for young people can really help to reduce distress. Again, we have to be mindful of the potential for that to increase distress and depending on that person's situation. So we need to explore that with them, but they might have certain people they can connect with who do feel really safe and can kind of help to reduce their distress. And then really any other form of distraction. And again, you know, thinking with that person about, you know, what are the things you enjoy or what are the things you find effective that kind of really take your mind off your distress, and sort of encouraging them to use those when they're getting to that point where perhaps they want to self-harm, or earlier ideally when they're noticing the distress increase. So I'm aware that's a real whistle-stop tour of alternative methods. So if anyone does want me to go over any of that in more detail or has questions, please do pop them in the chat. As I say, I think the key message around this stuff is really around trying to match it with that individual and making sure that it's something they feel comfortable trying out, not kind of imposing it on them, because generally we know that that won't work. So that's kind of the key thing to take away with this stuff. And just to kind of summarize really all of those key points, I just wanted to leave you with an acronym that we've kind of come up with, to try and capture kind of those main points. So we call it PAUSE, and PAUSE stands for panic, accept, understand, support and explore. So just to kind of explain each of these. So that first point, panic control, is really about that idea of sort of checking in with ourselves, you know, am I distressed? How can I bring that down? Try not to panic, try not to overreact. But equally, if, you know, if we're seeing the young person's kind of panicking, are there ways that we can sort of de-escalate that too? The second point is around that acceptance. So actually, you know, recognizing, okay, you know, this is where this person is at, this is what they're asking for, trying not to kind of allow our judgments to affect how we're responding to them. Again, being mindful of our own views and how that might affect that interaction. Then moving on to trying to understand the reason. So this is that exploring, you know, exploring the function, exploring the purpose of the self-harm, you know, understanding how are you feeling, you know, what's the self-harm doing for you? And alongside that, you know, being able to support them emotionally. So doing that validating, doing that empathizing, you know, praising them for bringing up something that's potentially really difficult to talk about. And then the final point is that exploring. So exploring the options with them. Actually, what do you want to do? You know, how do you feel about this? Do you want to change it? Do you want to just talk about it some more? Do you want to, you know, work on something else that might help you? So again, just really kind of being open and curious with that and exploring the options with them. So that's it from me in terms of content. So yes, whistle-stop tour of self-harm, and I'm aware I've thrown loads of information at you, so please do feel free to kind of ask any questions or anything else you'd like me to kind of go through again. Just to highlight, there are some further resources here, some apps, some books, some websites that I'd recommend. I think that the Mayden team is going to kind of put some links to these in the chat, but you'll also get the slides, so you'll have access to these. And there are just some references there as well for where I got the data from.
Thank you so much. That was really insightful, loads of practical advice. I think everyone's probably found it really, really useful. So thank you again. We are planning to share this afterwards. I was just looking in the chat channel, as well as the slides. So don't worry if you've missed some of it, it'll all be given to you afterwards. Whilst the Mayden team behind the scenes are collating the questions, including some that were asked before today, I'll just give you a brief history of these webinars so far. Bear with one moment. I'm just going to pop up a slide. hopefully you can all see that. It is just a slide about the type of people that we support here at Mayden. So we began these around a year ago. I believe it was last October. And we first heard from our customers, Bernardo's in the Northeast. They spoke about establishing MHSTs in the Morecambe and Barrow area and the key relationships that they needed to nurture as part of that setup. Then in December, we went on to welcome Helen McGlinchey of North Point Wellbeing, another customer of ours. And North Point have been running school services as well as MHSTs. And those school services in Leeds, Doncaster and Harrogate have been running for 14 years. So Helen was sharing her top tips for setting up effective mental health support in schools there. In February, we heard from our first specialist subject guest speaker, who was Dr. Dom Thompson. I know Rachel's worked with her before. Dr. Dom gave a talk on teen mental health, and she gave lots of practical advice, and you can find that collated in a blog on our website, iaptus.co.uk. And then more recently, back in May, we welcomed 2 customers from Young Somerset, not far from us, together with the clinical lead at Somerset NHS Foundation Trust, who work together to provide the MHSTs across the county. And we will be hearing again from that Somerset team at an event in London on the 17th of November. If you would like to attend, we will send out the info to you afterwards along with these resources. It'd be lovely to see you there. And then finally in July, we had lovely Georgina Rush from East Lancashire NHS Trust. She's a very experienced mental health practitioner, and she spoke on the importance of smooth transitions between stages of schooling, particularly primary to secondary school. We are planning a web page where you'll be able to access all of these really quickly and easily, but in the meantime, a lot of the information can be found on the iaptus.co.uk site under the blog section. Or please do just get in touch with one of us if you've got any questions or can't find something. If you'd like to find out more about the features in iaptus that support your service, you can get in touch with the team here via our website as well. There are more events planned. Hopefully we will be doing one in December. If you would like to speak at that one, please do get in touch with us. It would be lovely to have as many different services as possible speak. Or indeed, if there is a topic that you would like to have discussed, let us know that as well. We will be using Eventbrite again, so we will be emailing you with the next date, and please do scan Eventbrite as well, close to the time. So I believe the questions are now ready. I'm just going to stop sharing this and go back to the questions. Do feel free to add more in the chat channel as we go, and we'll see how many we can get through.
Sorry, I'm aware I didn't leave much time, Jen.
Don't worry, I haven't left much time either. So, Rachel, I think you're going to have touched on some of these already, but if you're ready, I will go ahead and ask the first question. So the first question is from Joanna, who is part of Wokingham Borough Council. And she has asked, do you have any tips for helping young people feel more confident about wearing clothes that mean their scars are visible?
Ooh, good question. So I guess probably the first step is around talking to the young person around how they feel about kind of the scars. And it's a tricky one, isn't it? Because I think some young people I've worked with actually don't mind people being aware of them, don't mind people seeing them, but for others it does feel like a very self-conscious thing. I think probably the best thing you can do is to model that kind of non-judgment. I think a lot of the time young people are so scared that if they show it to someone, particularly an adult, that we're going to respond in sort of a, a horrified or a disgusted way. So I think being able to say, actually it's okay, it's okay to have those scars, and really kind of just modeling that acceptance of it, I think is a really, really big step. I mean, in terms of, I haven't come across any specialist advice around that or any specialist tips around that, other than I think just using your other kind of skills in terms of building a trusting relationship, being open, being curious. Yeah, and I guess kind of problem solving with them if they're really not feeling confident to do it, thinking about, are there gradual steps they could take? So could they, I don't know, like, could they share it with people they're close to, like family? You know, could they practice kind of wearing short sleeves so that family can see, or that close friends, maybe they could start there and then they might feel able to kind of build it up gradually. But I think it's important to pick people they think aren't going to be judgmental around it, to kind of help them build that confidence. Yeah, I don't know if that answers your question, Joanne.
That was great, thank you. If it hasn't at all, please do pop another message through to us, either at the end of this or afterwards, and we'll get back to you. Our next question is from Raphael at Family Psychology. I can't speak. Family Psychology Mutual, CIC. He said, thank you very much. It's been a really useful overview. And that he notices there's a focus on the self-management and coping with self-harming, and wonders how carers or family can be effectively incorporated to support the young person who is self-harming. He's also curious about your views on safety planning and how to do this in a meaningful and productive way.
Thank you, Raphael. Yeah, again, really good questions. So I guess the first question is, I mean, in terms of incorporating family, I think ideally that would be fantastic if we can get people's family involved. You know, carers, you know, always try and promote that. I guess the tricky bit can be around consent with that. And I guess with young people, as long as they've got that GILIX competence, which is, you know, capacity to kind of make decisions for themselves, you know, we have to respect that. So if I was going in with a child or a young person, I'd always be kind of asking them, you know, how would you feel about us sharing this with your family? You know, it's really helpful to kind of have a support network involved around this. So that would be kind of the first step that I would recommend, is checking that out with them. Obviously, if they're very young, you know, the kind of level of competence is kind of trumped. So, you know, you would involve family. And again, I'd just be saying, look, I'm really concerned about this. I feel it's really important for me to discuss this with your family. And again, risk would always trump that confidentiality too. I think a lot of those tips that we looked at, I would be sharing with family too. So I would be saying, actually, you know, the best thing you can do as a family member is create an open space for the young person, you know, try and hold your judgments back, and try and not kind of react out of emotion if they do feel able to share this with you. You know, encourage them to talk if they want to. So again, it's just really kind of modeling that it's okay to talk about this. There's no judgment here. It's not a shameful thing. And if the young person then wants to, the family can be involved in the alternative methods too, so they can help them distract. They can do tip is a really good one, I think, often for parents to do with the kids. And often they quite like it as well, because they learn a way to regulate their own distress. Breathing exercises, also fantastic for that. They could sit down with a young person and kind of do the breathing together. So yeah, those would be sort of my main tips for that. Remind me what the second question was, Jen?
Safety planning.
Yes, safety planning. Yes, so I think safety planning can be fantastic. But again, I think it needs to be done carefully. I think it can sometimes come across as a bit tokenistic, or for young people particularly, they can feel that it's being done to regulate the professional's anxiety rather than to help them. So I think kind of, again, being very kind of clear around what, you know, why you'd like to look at a safety plan with them, you know, how do they feel about that? Do they think that could be helpful? And the safety plan doesn't have to involve stopping self-harm. As I said before, it can be around, actually, I'm going to keep my self-harm, but I want to work on maybe reducing my risks in these other areas, or I want to work on managing my low mood or my anxiety, or you know, or my trauma, or whatever it might be in these kind of other areas. So it doesn't just have to be focused on self-harm and stopping self-harm. That doesn't, I think sometimes people think that has to be the outcome of a safety plan, is that it's about stopping, and it doesn't have to be. I don't know if that answers your questions. Okay, yeah, I can see you nodding up there, thank you.
Kate from Bernardo's also had a question. Your thoughts on safety planning. Kate, does that answer everything, or is there something else you'd like to ask Rachel? If
no,
there's just pop
thank
it.
you so much. Yeah, that answers it for me. Thank you.
Thank you. We've got a question from Amy. And she said she's looking for something a little more engaging and age appropriate as a handout, because a lot of them are a bit too adult focused. So is there anything that you could recommend in terms of a good handout to share with the young people?
Yeah, I have come across the same issue. I mean, there are a couple of books which I can send kind of links through in a separate email to you, Jen, to be forwarded on, that are aimed more at young people, but they're often not specifically self-harm. They're more kind of around managing general distress. And to be honest, I haven't come across any kind of specific handout for young people. All of the stuff I use does tend to be with teenagers. I think often it's kind of appropriate for sort of 12-ish plus, but I think for the younger ones, I'm yet to come across someone. I don't know if anyone in the group has come across something though, that would be more appropriate for the younger age group.
Thank you. There's a couple of messages in the chat channel with people recommending things, but that'd be great if you could send us something afterwards.
Yeah.
I think just one more question has come through, but if somebody does have something, we have got a few minutes, so please do pop it in. And are there particular young people that are vulnerable to self-harm? Are there any family or social factors that are particularly relevant that you've seen?
Yeah, really good question. So as I said before, the statistics and the research is quite mixed in terms of what seems to come out. I mean, one of the common individual sort of traits is that perfectionism. So I think if you're aware, you're working with young people who seem to display quite high levels of perfectionism, avoidance of failure, making mistakes, etc., that's a key flag. In terms of family situation, I mean, I think it's similar to what you see in terms of general mental health. So families where you've perhaps got either trauma, that the young child is experiencing, and that can be big T trauma or smaller t. And so what I mean by that is, I guess your big traumas would be physical, sexual, emotional abuse, kind of more overt neglect. But I think the more kind of subtle traumas as well, so having quite an invalidating environment, so parents who are not very emotionally available is a common theme, or quite critical, who kind of, I guess, exacerbate that perfectionism is quite a common one. In terms of also, I guess, parents who have their own trauma, and we know that kind of trickles down through generations. If perhaps parents don't know how to manage their own emotional distress, then that kind of gets put on the child, and then they don't know how to manage their distress, so they're more likely to resort to things like self-harm. Yeah, and I think in terms of social factors, I'm not sure actually. I mean, I think things like, again, kind of the general mental health. So if people come from a lower socio-economic background, they're more likely to engage in those sort of behaviours. But I don't know, I tend to not like those generalisations so much, because I think it takes away from the individual. But yeah, that can be one of the things that can be a factor too.
Thank you. Thank you so much. We really are very grateful for you joining us today. It's been brilliant. And we will be making the recording available to everyone for a set amount of time, and we will send the resources. I'm just going to share a whiteboard again. Hopefully this one will be more behaved than the map at the beginning of the webinar. And it's just a place for you to be able to pop down any questions either for us at Mayden or for Dr. Rachel. If you can't use the whiteboard, please just pop it in the chat channel. And if there's any particular topics you'd like to see at either our next webinar or one after. The topic of self-harm actually came as a suggestion from one of our previous webinars. So we do listen. It might be that you want more opportunity to network and talk to each other in breakout rooms. Let us know that too. And we will be in touch with details of our next webinar soon. If you are a customer of ours, a special thank you for joining. And as ever, if you need any support, please contact us via IAPTUS and your account manager will be in touch. If you're new to us, my colleague Martin, who is on the call and may be waving, may not be, will be holding a short information session on the 25th of October, where we'll be talking about some of the challenges faced by MHSTs, especially around data and reporting, and how the features in IAPTUS can help with those. The link to sign up to that should be in the chat channel now, and will be sent afterwards. So that's it. A big thank you again to Rachel and to everyone for coming. Please feel free to leave the call when you're ready, and have a good rest of your day.
Thank you, everyone, and thank you, Jem, for hosting.
Thank you.
Thank you very much, Rachel. Very informative.
Thank you.
You're welcome.